can stabilize the endoscope by keeping it in contact with the dura at the craniotomy. If endoscopic improvement of the Teflon is required, we favor a one-handed procedure with the surgeon guiding the endoscope and the instrument due to the narrow working canal. Only rarely, when bimanual dissection is required, the endoscope is fixed to a mechanical holding arm. On successful decompression, neuromonitoring shows the disappearance of the lateral spreads. For the retreat, the dura is closed in a watertight fashion. In addition, Tacocil is applied to the dura. Open mastoid cells are closed with muscle and fibrin glue. After multi-layered wound closure, an overhand skin suture is performed. Positioning is the key to successful surgery. The head must be rotated far enough to allow the cerebellum to fall back, while prevention of any compression of the jugular veins, as this significantly increases the vulnerability of the vessels that are manipulated during surgery. For a successful approach, the dura incision has to be close to the sigmoid sinus, otherwise there will be an insufficient visual access to the paramedullary space. Though microsurgical view alone provides perfect illumination and magnification, while still enabling the surgeon to operate two-handedly, especially deep and medial compression locations at the pontomedullary sulcus or hiding behind the lower cranial nerve group are difficult to visualize, but are easily seen when using a 45-degree endoscope. Threaded Teflon placed directly on the decompressed nerve may also cause a recurrence of the spasm. It is important even in cases of very limited space not to position the Teflon on the nerve itself. In case of recurrent spasms, the removal of the previously placed Teflon alone may cause the spasms to disappear. In many cases, mastoid cells are opened during the approach. These cells must be sealed sufficiently with muscle and fibrin glue under the retreat of the dural closure in order to prevent the risk of CSF leak and postoperative meningitis. In case of a CSF leak, rhinoliquorrhea occurs due to the opened mastoidal cells. In case of uncertain findings in the postoperative period, a better trace test or intrathecal administration of fluorescein may be performed. At CSF leak, an elevated upper body position of 30 to 45 degrees and the lumbar drain for several days may be attempted before deciding to perform revision. If possible, the aim is to perform a transposition of the compressing vessel rather than an interposition of Teflon. To achieve successful transposition, 3 options depending on the patient's individual anatomy can be chosen. Most often, insertion of threaded Teflon between the brainstem and the vessel is sufficient for decompression. Alternatively, a Teflon bridge is placed parallel to the brainstem surface between the lower pons and the flocculus, shielding the root exit zone from the compressing vessel. Often, an additional piece of threaded Teflon is placed as a pillar to increase the distance between nerve and vessel. In some cases, due to the tension of high-caliber vessels, a reposition by a Teflon sling is required. After proper arachnoid dissection and mobilization of all compressing vessels, the Teflon sling is placed in combination with a Yazagal clip to fixate the vessel in a sufficient position at the skull base. In these cases, it is even more important to rule out any vascular kinking after performing repositioning. In our series of about 500 MVDs, in 14.5% of cases, patients faced hypoacusis directly postoperative, resulting in permanent anacusis in about 3% and persistent hypoacusis in about 4% of cases. Facial palsy was seen in about 8%, but only around 1% of patients suffered from permanent deficits. Temporary hoarseness as a sign for lower cranial nerve deficit was seen in about 3% of cases. In conclusion, the endoscope-assisted macrovascular decompression in hemifacial spasm is an elegant procedure overcoming the limits of the purely macroscopical view on the compression side, resulting in excellent outcome with a great impact on the patient's quality of life.
Thank you, Professor Schroeder, for that excellent video. My first question to you really regards to your slightly unusual way of positioning the patient. How do you position yourself? Where is the surgeon in relation to the patient in that way?
I sit on the side of the approach. Some people say it's not good. It's better you make this park bench position because then you work 45 degrees downwards. But the retraction of the cerebellum is better in this approach because it falls back by gravity better. When you make this park bench, you have more to retract. So I don't use any retractor. I just cut the arachnoid over the lower cranial nerve group, and then I can mobilize it and the cerebellum goes back. For the patient, the positioning is ideal. For the surgeon, many people are complaining. But I have no problem with that. You know, it's not a long-lasting procedure. And I think the relaxation is very good. So we tilt the head just 45 degrees to have no venous congestion. Then you bring it a little bit up, and then we turn the table, the whole table. There is a support on the chest and the pelvis.
Right.
Then we can rotate the table.
You make a very strong point in your video about the contact between the Teflon pledget and the sponge and the nerve. There should not be any direct Teflon attachment to the nerve. How did you come to discover that idea?
And we have, I think we made 35 recurrent cases. And in most of them, the reason for the returning hemifacial spasm was simply the contact between the Teflon and the nerve. In many cases, I just removed the Teflon along the facial nerve. Meanwhile, the offending vessel was fixed by scar formation to the skull base, so it could not fall back. I just removed the Teflon, and that's it. And then the hemifacial spasm stopped. And this occurred in the majority of our recurrent cases.
Interesting. So this was from personal observation that you then modified your practice of not having the direct Teflon contact. Is that different in your mind between the seventh nerve and the fifth nerve? Does it apply also to trigeminal, or is it specifically?
I do usually make a transposition with a sling to mobilize the SCA, put it parallel to the tent, and then I put a Teflon sling and fix it with an aneurysm clip. For me, it is an ideal decompression. Doesn't matter whether it's hemifacial spasm or trigeminal when there's no contact at all between the nerve and any material. And
let's talk about that sling a little bit. You use a Teflon sling, which I find very interesting because
Teflon
some people use Gore-Tex. You use Gore-Tex as well?
Yes.
Okay.
Gore-Tex has a disadvantage that it's very stiff. And when you bring it around the vessel and push, the edge of the sling may vulnerate the wall more. That we had one problem in one case where I put a Gore-Tex sling. It was elongation of the vertebral artery. I put it to the dura, fixed it with an aneurysm clip. It was very nice, but there was a small perforator which was close to it, and because of this traction, it was not perfused, and the patient developed an brainstem infarction. This does not happen in any of the Teflon slings because they are at the edge more soft. So that is a difference. But for the larger vessels, I usually take Gore-Tex.
What are your tricks about where to attach that sling, specifically to hemifacial spasm?
It depends from many factors. It's an individual anatomy. Where is the sling touching the nerve? Sometimes you can pull it a little bit backwards. Sometimes you have to pull it more anteriorly. Sometimes there are perforators in a special area where you never can put a sling. So you have to bring the sling more to the back or to the front. So it's always very important that you look for the perforators because these are at risk when you use a sling technique.
I see.
And then it depends from the anatomy. Usually I go in between the internal auditory canal and the jugular foramen, and I make a tunnel in the dura, and then I put one branch of the clip under the dura and the other clip to the sling.
How do you advise your patients regarding the timing of the stoppage of the twitching?
But sometimes, even if I see there is no contact between the vessel and the nerve, sometimes still there's persisting lateral spreads. So what can you do better? Nothing. And then it takes sometimes months until it becomes a good result.
It's very important for younger surgeons to understand that you're not treating to the lateral spread, you're treating to the decompression. And if that the decompression is done fully, then the lateral spread would just have to be what it is. Your endoscope, obviously, that was a big point in your video as well. You use a 45-degree endoscope to look around the corners. Are you using that universally for every case, or is it a case-by-case basis?
Always I use.
Always.
Yes, I want to see down to the pontomedullary sulcus, because that is a way, or that is a location where many offending vessels were missed. Nerve group, sometimes the lower cranial nerve group is it's really like a wall. You can it's difficult to look behind. With 45-degree, you always look without any retraction, and you see down to the pontomedullary sulcus. When you have an endoscope in and you fix it to an holding arm, which is very rarely required in hemifacial spasm, you have to make sure that you irrigate a lot, because if it becomes dry and the endoscope tip is hot, it may damage the nerves. This is very important. And also when you have passed a nerve and you work in the depths, you don't see what your instruments are doing to the nerves which are behind the lens. And this is the second thing where you have to be very careful when you use an endoscopic technique.
Again, thank you, Professor Schroeder, for that outstanding video. I thought it was exceptionally clear. And on behalf of Operative Neurosurgery, I thank you for your contribution.